We'd like to ask Dr. Nigeshwar Reddy to come to the stage, please. So the next talk will be by Dr. Nigeshwar Reddy. He's a well-known doctor for his achievements. He is currently the chairman and the chief gastroenterologist of the HN Institution for Gastroenterology and the AIG hospitals. He had a lot of contributions to the field of gastroenterology and to medicine as well. He had published more than 1,100 publications, and he contributed to more than 50 textbooks. And he had so many awards, and there is no single year where he was not awarded from different bodies. But he's the only doctor who got the ASGE award for the 5 years, 5 times. And he got lately the Johns Hopkins University prestigious captainship for 2024 as well. So welcome to our conference, Dr. Nigeshwar, and the floor is yours.
Thank you. I was actually here probably for the first workshop ever in Saudi, maybe 30 years back, by Professor Al-Karawi, and I remember that very distinctly. Then I was there for a couple of times, and then after a long time came back, and it was very pleasant to see huge change has occurred, not only in the society as such, but also the hospitals. Everything has changed so much, and I'd like to thank the organizing team for giving me this opportunity to be here for this workshop. My topic is on the tools that we have to use for CBD stone, and after the nice talk by the previous talk, my task is easier. In 1973, Klassen and Kawai did the first biliary sphincterotomy for removal of the CBD stones. Since then, there have been several changes. In fact, after they did the first sphincterotomy in 73, they did not have any tools to remove the stones. For the next 2 years, many of these patients developed cholangitis, and actually 3% died. After 2 years, balloons, baskets, and so on came, and subsequently removing the stones became easy. In about 90-95% of the times, we can remove these stones easily, but 5 to 10% of the time, the stones are not easy to remove, and they are called the difficult CBD stones. Now, how do you define difficult CBD stones? Difficult CBD stones are those which is size-wise more than 1.5 centimeters and therefore cannot be removed by standard techniques, or there is a stricture which is below the stone and therefore difficult to remove. Mirzi syndrome, again difficult to remove, and intrahepatic stones, which are actually also not very easy to remove. So these in general are categorized as difficult CBD stones. What happens with ERCP, I think Khalid has shown very nicely the difficulties in cannulation. But even after cannulation and you go inside the bile duct, sometimes there can be complexities involved removing these difficult CBD stones. So when the stones are large or the lower part is narrow, you have to either dilate this part and remove the stones or fragment the stones before removing them. So we have several techniques of fragmentation of removing these stones. But before we fragment, we'll have to open the sphincter completely. Standard sphincterotomy is not actually effective in most of these patients. So now, in 2003, the Turkish group actually first showed us the technique of balloon sphincteroplasty, partial sphincterotomy followed by large balloon sphincteroplasty. And since then, there have been several RCTs showing the superiority of this. Has become the standard technique for removing large CBD stones. So you can see we can actually dilate the sphincters to about 15 millimeters, and then stones very large also can be removed. That's because there's a radial dilatation of the sphincter, not a single cut, and much larger stones than what we think can be removed by this technique. So even 1.5 centimeter stones very often we remove just by doing this balloon sphincteroplasty. And you can see very nicely here how these stones come out. Based on this, several new devices have come in. For example, you now have devices where a balloon is attached to the sphincterotomy itself so that you can do both the procedure together. You have different types of baskets which have been made which can catch even these very difficult stones and so on. But basically, the basis is a balloon sphincteroplasty, and I think there's been a lot of work in this area. The Asian group, actually, we put certain guidelines, what should be the balloon size, never more than 15 millimeters, duration of the dilatation 60 seconds, and sphincterotomy should be about 50% of the sphincter. And if no sphincterotomy is done, we always put a pancreatic stent to prevent pancreatitis. And if you have to crush the stone in spite of a balloon dilatation, that mechanical lithotripsy has been the standard techniques. You can see there are two types of mechanical lithotripsy that is available. The Sohendra one, which we used to use earlier, was an emergency lithotripter. If you can't remove the stone or the stone is stuck, then you put this in, and using this mechanical lithotripter, you remove the stone. Of course, the problem, of course, is you sacrifice the basket and you have to remove the stone. It involves a lot of drama in this. Intraductal mechanical lithotripsers have now become very commonly used, and you can see the one that we use commonly is the BML one, where it's a 3-layered technique where you have a basket, a metal sheet, and a plastic sheet all together, and you crush the stone between the metal sheet and the basket. This is quite successful in majority of the cases, but there's certain limitation. I'll come to that a little later. You can see how effectively mechanical lithotripsy can actually crush the stones. You see, it has to hold the stone around completely. And then when it holds this, what happens is the stone breaks exactly in the center. If you don't hold it around completely, then you have a problem because stones are different. And if you have an impacted stone, you can't get a basket above. This is a problem. You should be able to open the basket around the stone, completely catching all the layers. Sometimes if the stone is very large, you can't, then we put a stent and then come back a little later. But you can see very clearly here, the mechanical lithotripsy failure rates occur once the stone size is about 2.5 centimeters. So it's effective only up to 2. If the stone is more than 2 centimeters, you should not start doing mechanical lithotripsy because success rates are very low. So this was data which came from ASG, which showed clearly that in large stones, if you do papillary balloon dilatation with sphincterotomy only and remove the stones, your success rates are 96%. These are stones which are 1.5 centimeters or less. Just plain sphincterotomy success rates are much lower, and there's an increased need for mechanical lithotripsy. So sphincteroplasty is what we are effectively doing most of the time now. More advances have occurred, and the advent of single operator cholangioscopy, of course, has made a difference. And along with laser and EHL, we can now break the stones very easily. The principles are clearly known. We have 1 millimeter distance from the stone. Stones are fragmented into small bits, and these can be very easily removed. And this is just a video showing that we can actually target the stones very easily, and you can see the laser probe in the current cholangioscopes come at about 6 o'clock position. So you can very easily target it, and of course, I don't want to go into the details of the settings, but you can, based upon your experience, different machines have different settings and so on. Invariably, a success rate of fragmenting the stone is almost 100%. A cheaper technique is EHL. It's more powerful, but the problem with EHL is that you have to target the stone. By mistake, if you hit the bile duct wall, you can actually produce a hole there. And therefore, although it's sometimes more effective and very strong, you have to be very careful when you're using this, and you can see that you have to target it very carefully. So again, there is a lot of series, a systematic review and meta-analysis showing that overall fragmentation rates approach almost 90%, single session fragmentation 80%, and very little adverse effects. And you can actually clear most of the stones, and this is something that's become standard. There have been 3 studies now comparing laser lithotripsy or EHL along with mechanical, and you can see from this first study which came from Los Angeles that using a mechanical basket versus laser, there's a huge difference, 93%, 67%. So if the stone is large, I think we directly go to cholangioscopy, don't waste our time. This is again Florida group, which showed that success rate with laser much higher than mechanical lithotripsy. And here, the most important is the stone bile duct ratio. If the stone bile duct ratio is more than 1, don't try any other methods, directly go to a cholangioscopy. And again, work from Asia showing very clearly that laser lithotripsy is much superior to mechanical, especially if the stone size is more than 1.5 or the size of the duct is less than the stone, lower down. So the usual use of cholangioscopy is stones more than 2 centimeters, unusual location, or a distal stricture. In our unit, we have a huge experience with extracorporeal shock wave. The reason we use this more often is that it's very easy. You just put a nasobiliary catheter. If you have a good extracorporeal shock wave in the hospital, just send out the patient. So it takes 5 minutes for the ERCP. Send the patient for ESWL. The ESWL guy breaks the stone completely. And then when you come back after, say, half an hour, you don't even have to do an ERCP. You just have to flush, and all these fragments completely come off. So this for us is an advantage because it saves the endoscopist's time. It's much easier procedure to do, so we use it a lot. We reported a large series where we successfully fragmented these stones. So just to show you pictorially that if the stone size increases, you require other techniques. So 1 centimeter, very easy, sphincterotomy and remove. 1.5, balloon sphincteroplasty. 2 centimeters, mechanical lithotripsy and remove. If it is above 2 centimeters, you have to always do cholangioscopy or one of these techniques of intraductal lithotripsy. For very large stones, if you actually cannot take, or you don't have all these very high-end procedures in your hospital, a simple technique is to put in a stent. I would suggest even 2 stents. Put in 2 7-French stents, and you come back after 3 months, you'll find very surprisingly, the stone size has come down. Sometimes it's fragmented because the stents are acting in it. And in fact, even ESG guidelines would suggest this, and this is a Japanese study. We showed that you put in multiple stents, come back after 3 months, the stone sizes come down, stone is fragmented, the stone volumes have come down. So this is a simple technique that you can use in your hospital. Intrahepatic stones invariably will require some sort of a cholangioscopy to remove the stones. And you can see here, they are associated with strictures. You have to be careful that there's no associated malignancy. Once you rule out, we now have 7 French cholangioscopes with a 1.2 diameter channel, so you can put in all these lasers and all. So we are now commonly using the 7 French cholangioscopes which have come newly, and you can access any part of the intrahepatic bile duct with this and remove the stones. And this is an example of a stone here you can see. It's a small stricture. We go inside and you can actually navigate this narrow ducts through this and then go inside, and then you can see the stones there, which can then be fragmented using a laser in most instances, and completely the fragments can be removed. So to a large extent, the stones, wherever they are, whatever size in the biliary tract, can now be taken out using these techniques. Mirzi syndrome is another very important indication for doing intraductal lithotripsy, and this is a classic example of a stone which cannot be removed by conventional technique because part of it is in the cystic duct. We then use the technique of, again, laser here you can see, very easily fragment the stone, and there now again very large number of series is reported where Mirzi's has been very easily tackled using cholangioscopy and laser. Few difficult areas where you have to use certain techniques. If we have a stone impacted in the proximal part, a large CBD stones, one of the tricks is to use a guide wire to get across this, and then try and manipulate with the endoscope, and we now have rotatory baskets which can be passed on this guide wire. Pass the rotatory basket and rotate the basket, and you find that sometimes the stone slips into the basket, which then can be removed, or you can put a temporary stent for a certain period of time, and then you'll find the space between the stone and the duct increases, and you can remove this. But if the stone is impacted in the distal part of the CBD, which is more difficult, more sometimes dangerous consequences because of severe cholangitis, we don't try primary removal. If you have an impacted stone in the lower part of the CBD, just put in a stent or a nasobiliary catheter and then come out, and then you can go in afterwards once the cholangitis settles down to remove these stones. Of course, we have sometimes used this direct cholangioscope. You can use a pediatric scope, pediatric upper GI scope, go into the bile duct, and then you can use all sorts of tools. You can put baskets, you can put large laser fiber through this, and then these stones can be completely fragmented and removed. There is some tendency now, and you can see my colleague Dr. Mohan Ramchandran is involved in this paper, that radiation should be avoided, and there are a large group of ERCPists who believe that we should now go into radiation-free removal of the CBD stones. In fact, if it is done in expert center using the new types of cholangioscopes without radiation, and using all these new accessories which can be passed through cholangioscope. Many of these stones, less than 1 centimeter, can be removed radiation-free. I myself am not a strong proponent of this, but there is a group of endoscopists who are strong believers in radiation-free removal, and we now have accessories for this. Intracholangioscopic accessories which can be used to remove these stones easily. So this is sort of a chart algorithm to show you what we do. If it's a difficult stone, usually 1.5 to 2 centimeters, the stone is not impacted, we would do a endoscopic papillary large balloon dilatation, and stone can be removed. If the stone cannot be removed because the stone CBD ratio is less than 1, then mechanical lithotripsy can be done. If the stone CBD ratio is more than 1, you can never remove this by mechanical lithotripsy. Always, so that's the reason why you should measure the stone size and the CBD below size. If it's more than 1, then you have to go for some form of lithotripsy using a cholangioscope. In spite of all this, if you can't complete or you have done it partially, my suggestion is put in a biliary stent, come back after 2 or 3 months, and then you can be very successful in most of these cases. This is the algorithm we would normally use. Of course, there are changes occurring in this, and to conclude, most stones can be removed endoscopically. Papillary balloon dilatation is the most commonly used technique to remove larger stones. Mechanical lithotripsy we are using less and less. It's a difficult procedure, not cost effective. I think cholangioscopy is becoming now cheaper and can be very easily taken out. But some changes are occurring. In fact, recently, there's a group at Stanford with whom we are working, at Stanford and Mayo Clinic, who have started making capsules which can be manipulated from outside. You can actually put in a capsule endoscope, manipulate it with a joystick from outside, make it go to your papilla and so on. So these are techniques coming in. Large CBD stones, you have several techniques, endoscopy, laparoscopy, surgery. It's very important to remember that we are one group. If you have a good laparoscopic surgeon, send it to the laparoscopic surgeon. But the new capsule may change all this, and this is the example. So these capsules probably are available in supermarket. The patient goes there, has a CBD stone, goes inside, the small robot coming out. These are now technically feasible. Just last month we had a meeting in our institute where this capsule was demonstrated. So the robot goes inside and a unique way of taking out the stone. You can see it's coming out. So I think this is going to be sometime in future, not now. If you have a stone now, the patient has to come to King Fahd Hospital. Abed or somebody has to do a ERCP to remove the stones. Thank you very much for your.
Thank you, Dr. Reddy.